I'm going to talk about sort of the next step. So, you know, Rebecca's covered the, you know, what can you do when you've got that first early suspicion, you've got your patient in front of you. The pharmacist has told you they've not collected their last 2 scripts, or the family have rung you ahead of the consultation and said, you know, Dad's had 6 crashes in the last 2 weeks, or whatever the issue might be. There's a little tiny bit of overlap with Rebecca's talk, for which I apologise. That's my fault, not hers. And again, please, please, please chip in, make comments, ask questions. The more discussion we get going, the more I think we all get out of it. So, I think it is useful to keep reminding ourselves and go back to what is dementia. So dementia is, essentially it is a clinical syndrome, and it's a disorder characterised by altered cognition that interferes with function. And I think that is a very key point that we have to remember. It isn't just memory. There are lots of modalities of cognition. Previously, the definition of dementia had to include memory and one other domain, but the most recent classification systems actually recognise that you can have alteration in the other domains before you get the memory loss. So, you know, any sort of cognitive change that's interfering with function. And it has to be distinguished from something else, mainly because the something else's are potentially more treatable than dementia is. So this will be of absolutely no news to you. You hear this almost every day, you know, or quite frequently. So the sort of things that people report, and it may be the person themselves, it's often a family member or other informant. Someone mentioned right at the start, they miss appointments. They don't remember appointments. And a really useful strategy to get someone to an appointment and get an informant at the same time is to say to the person, I think we need to make another appointment because you missed the one you had. And I think it might be helpful if we were to send a copy of the appointment to your son or daughter or other person. And then that's a way of inviting that other person into the consultation as well. So that's, you know, a handy hint. Problems remembering recent events. So one of the things that I often hear from families is Mr. Smith can remember what happened 40 years ago, but he can't remember what he had for breakfast. And this is because the way our brains work is the longest and strongest memories are the most hardwired. So, you know, typically, even with dementia, with progressive memory decline, the longest, strongest memories are the ones that hang around. And it's the recent events that become an issue. Struggling with complex tasks that previously wouldn't have been a struggle. So managing finances. A common one for ladies, and I acknowledge that men cook as well, in fact only the man in my house cooks, is not being able to follow a recipe anymore. So, you know, people who've been avid bakers or bakers from necessity suddenly can't follow a recipe, or not so suddenly. Inability to cope with the unexpected. Rebecca, you touched on that, and that is something that is certainly needs to be taken into consideration when you're thinking about things like driving or other potentially hazardous activities. Getting lost in familiar places. Now, you know, I occasionally go into a room and can't remember why I've gone there. But if I retrace my steps or I stop and think about it, I can usually work out what it was that I was doing. But for some people, as their condition progresses, they actually stop recognising familiar environments. And that makes it even harder to cope with an unfamiliar environment. So one of the challenges we see in secondary care is that when people are admitted to hospital who have cognitive issues, they often get much, much worse. And you'll see the same when people perhaps make the transition into residential care. They often get worse before they settle. Language issues can happen, word finding problems. Interestingly, and again you touched on this, Rebecca, people for whom English may not be their first language, you may find that they start to revert to their native language even if they've spoken English here for decades. And we see that not just in dementia, we see it in other brain injuries including stroke. And also,
I once had a patient who had delirium who was in his 80s and Maori, and he reverted back to Te Reo from his childhood, which he actually wasn't even allowed to speak at school. So it was kind of, you know, it was like hearing an archival recording. It was amazing.
I've actually seen that too with a Maori lady, and I've certainly seen it with people who are immigrants from Germany and other non-English speaking countries. And altered behaviour. Dr. Adam Sims this afternoon is going to talk about behavioural and psychological symptoms and signs of dementia. But this can be one of the most challenging things for families and healthcare workers to have to deal with. And I think as healthcare workers we need to be very mindful that there are other solutions than just drugs. And you know, sometimes it's too easy to think about sedating people, but it's harmful and we should avoid it if we can. So just taking a step back, from your primary care perspective, what I'd like you to think about is that common things are common. Now, dementia is increasingly common. It's an age-related phenomenon. Does anyone know how old you have to be to have a 1 in 2 risk of having some dementia? 85. Not bad guesses. Fortunately, it's a bit older. It's in your 90s. So 1 in 2 people in their 90s will have, you know, some degree of dementia. But it is something that we're seeing more as people live longer, because people are tending not to die of other things as much. And it's often referred to as the epidemic of our time. I'll give you a sobering statistic, and this, I have checked this, it is true. In New Zealand every day, about 1 in 24 people are diagnosed with cancer. And about the same number will be diagnosed with dementia. Of the ones with cancer, half of them will be cured. And the others may well get some remission and effective recovery, albeit not a permanent cure. None of the ones with dementia will be cured. They'll all get worse. A lot of them will end up institutionalised and they'll all die. If they don't die of something else first, they will die. And it is something that we have to be mindful of. Dementia is a terminal illness. It is a life-limiting illness. And we need to, we do need to think of it as such. But common things are common, and most dementia is Alzheimer's disease, or it's vascular dementia, or it's a mixture of the both. And to some extent, all the other subtypes of dementia, which I'm sure you will hear more about later today, are a bit more academic. And they're the ones where, you know, if the pattern of the illness isn't behaving like you expect an Alzheimer's or a vascular dementia or a mixed dementia to do, they're the ones that we want you to be thinking about referring on for further specialist assessment.
Is the incidence of physical medical problems higher in people with dementia than those without dementia? Because it often seems you get an elderly patient who's been doing quite well, and then you start thinking, oh, their cognitive function's a bit declining a bit, and then their heart failure seems to get worse, or they have a stroke, or something else happens that they actually sort of head down the slippery slope a lot faster than you.
Absolutely, yeah, you are absolutely right. If a person has managed to get to a ripe old age with absolutely no comorbidities and they develop dementia, their life expectancy is diminished. And towards the end of their dementia illness, they will definitely have physical symptoms. One of the commonest physical symptoms of dementia is anorexia, so they lose their appetite, they stop eating, they lose weight. And then they get all the complications of weight loss. They often become less mobile, they get all the complications of immobility. So there is absolutely no doubt that a dementia leads to a physical decline as well. You know, as to why, you know, can I explain why someone with dementia's heart failure suddenly gets worse? I can't. Some cleverer person might be able to, but, you know, I think there are lots of reasons. It may be that they're not managing their medications as well. It may be that they're not following a fluid restriction well. It may be that, you know, their heart failure was going to get worse anyway. But yes, you definitely see an increase in physical decline as well as the cognitive issues. Yeah. So, just going back to what I was saying, you know, we want to know about the weird and wonderful ones because sometimes we can offer some practical advice and solutions. When I first started working in my current post, the waiting time to see a geriatrician was over 6 months. Now, with the greatest of respect to my predecessor, who I adore and respect, he was not as ruthless as I am about turning referrals round. And I would see referrals that said, thank you for seeing this 90-year-old lady whose family report she's a bit forgetful. If you send that to me, you'll get it back. And I will say, do the basic workup, use the decision-making tool, use the map of medicine, use whatever your local algorithm is. You know, if you think it's a straightforward, albeit horrible, dementia like Alzheimer's, follow the algorithm, try some medication, may or may not work. If there's something weird and wonderful, send them back to me. But, you know, that's not going to fly, I'm afraid. You know, a bit forgetful. And often in those circumstances, you can't even get a sense if the patient knows they've been referred. A little bit more about investigation. Rebecca, you sort of nicely opened this up. In actual fact, there's very little evidence to support routine screening for people with cognitive change. And it is very much about trying to rule out things that you can reverse. So again, common things are common. Things that can present as cognitive impairment and are potentially fixable are pernicious anemia and hypothyroidism. So most guidelines will suggest that you at least check those and, you know, rule out an anemia. Everything else needs to be guided by clinical suspicion. So we don't, when I was a junior doctor, if people presented confused, we routinely checked them all for syphilis, but we don't do that anymore. But you may have a clinical suspicion, and I have diagnosed one neurosyphilis in my career, and that was a lady who was an absolute respectable pillar of the community, very lovely person, I'm not judging. Turned out when she was young she had worked for a while as a prostitute. Not judging, but she had neurosyphilis. Calcium, if there's a history of cancer, cancers can come back. So think about the calcium, and that might be an indication as well if there's an index of suspicion for certain imaging, things like chest x-ray or brain imaging. Younger people with rapidly progressive symptoms, you need to think about things like CJD or Huntington's disease, and they need more specialist assessment. And particularly Huntington's disease, of course, has a wider implication because it's genetic, and it may mean that the wider family needs to be screened as well. There are tests for Alzheimer's disease. I was a little bit shocked a couple of years ago. I went to a conference in a country not too far from here. And if you turn up to certain centres in said country with $6,000 in your pocket, any of you, me, you, yeah, if you turn up and say, I want to be screened for the risk of getting Alzheimer's disease, they will do it. There'll be blood tests, there'll be PET scans, there'll be lumbar puncture. You'll go through this whole gamut, and at the end, they'll tell you what your statistical risk is of developing Alzheimer's disease. Why you would want to know that is you know, for you to decide amongst yourself. But it's not routinely recommended. It's really only done in research circles reputably, and it doesn't have a very good sensitivity or specificity. So we don't do that here.
The ones that are autosomal dominant, would you then think about doing genetic testing?
Well, you'd only know that if you'd done genetic testing.
But so, you know, if you've got, so if your parent has been diagnosed with young onset and their genetic testing will come back that it's autosomal dominant, would you then say?
I think I would probably have a discussion with the patient about it and, you know, outline the limitations and you know, obviously get a sense of what their wishes would be. Like all these genetic tests that can potentially reveal a horrible diagnosis, if you can't do anything about it, do you really want to know? Some people do, some people don't, but they have wider implications. You know, it can mean that you can't get a mortgage, for example, or insurance. So, you know, again, I think you have to take it on a case-by-case basis, but it's certainly not routine to do these tests. Again, neuroimaging is quite controversial, and local guidelines do differ. As Rebecca told you, in Wanganui, GPs can access CT very readily, but not MRI. And, you know, the decision as to whether you do a CAT scan should really be clinically guided. If someone's got multiple vascular risk factors and they've, you know, maybe even had a history of a stroke or TIA or ischemic heart disease, do you really need to scan their brain to know that they're going to have some cerebrovascular disease? Often, I think people expect that they're going to get a scan, and families expect that they're going to get a scan. And, you know, I would argue that there are times that imaging is actually therapeutic in that regard, that it, you know, it does reassure people that it's not a brain tumour or whatever. But, you know, again, it should ideally be clinically guided. And again, it's very much about ruling out alternate diagnosis. So if there's if someone's had a fairly rapid cognitive decline and there's a history of recent head injury, you might think, could this be a subdural? It's reasonable to want to do some imaging. Normal pressure hydrocephalus is that syndrome of wet, wacky and wobbly. So they become incontinent of urine, they have cognitive decline and they're unsteady on their feet. And that's potentially treatable. So yeah, wet, wacky and wobbly. Have you heard that one before? It's not very respectful, is it really? But we have to have ways to remember things. Typically, if you do basic neuroimaging, what it will either show is some shrinkage of the brain, which may or may not be in excess of what's expected for the person's age, or it may show some background ischemic changes, or it may show both. So again, question, is it going to change your management of the patient? There is some potential for using functional neuroimaging, so these are your functional MRIs, the PET, SPECT things. I don't have access to any of those routinely, and they're really only mainly being used in research at the moment. But again, just be mindful, sometimes people have an expectation that there's going to be a scan, and they get, you know, they can be quite plaintive. Yeah, are you not going to scan me? But, you know, again, it's about education and reassurance that it's not going to change anything if you think it's not. I've never referred anybody for a brain biopsy ever, not even in suspected CJD, because there's usually other corroborative clinical features or EEG findings. Occasionally I've done LP where, you know, where it's been suspected. And you know, I wouldn't really want to put an elderly demented person through a brain biopsy if it wasn't going to make any difference. And it's an operation, it has high risk of complications. So you would typically reserve it for, again, the atypical, so younger patients. Maybe if you think there's something like a vasculitis, if there's a history of lupus or something like that, and you want a confirmatory diagnosis to guide treatment. So just coming back to basics again, it's mostly Alzheimer's or vascular or a bit of both. So what can you do? Well, as doctors, of course, we love drugs, but there's always other things you can do. And I think the other things are more important in the management of dementia. So the non-pharmacological aspects. So wrapping around the supports for the person and, crucially, their caregivers. The vast majority of elderly demented people are being looked after by other elderly people that they happen to be married to. And they usually have their own health issues. And, you know, I have conversations with spouses who are exhausted, and you can see it. And they say, you know, but I made a vow till death do us part. You know, I made that vow too, and it, you know, mine meant something to me, so I know theirs means something to them. And it's really hard to say to someone, you can't keep doing this by yourself. And I often say to people, you know, I don't work 24 hours a day. I have in the past, I was a junior doctor, but I don't do that anymore. There's no way I could do that all day, every day. Nurses don't work all day, every day. Therapists don't work all day, every day. Caregivers don't work all day, every day. Just because it's a job of love doesn't mean it's not a job. And in a job, you're allowed to ask for help. So, you know, we need to be very mindful that these are also the same population that we're treating and support them. Now, again, there are informal supports. Age Concern may offer sitting services, for example, to allow the person to have a break. There may be other family members who can help out. There may be volunteer services. And then obviously you've got your formal supports, and how you access those locally, again, may differ slightly from place to place. Formal supports are limited, as we all know, and they don't, you know, routinely provide people with support in their own home 24 hours a day, but it's still useful to access them when people are eligible for them. So then we do come to the medication. Oh.
Just on that support, quite a common scenario is where the wife's exhausted, for example, and her husband's got moderate dementia. She feels guilty about him having some respite, but more significantly, he absolutely refuses to leave the house.
I know.
And so, short of actually picking them up and forcing them through the door, so you can see this person's caregiver wearing themselves out, and you've got someone with little insight and quite an obstructive or strong personality who simply won't leave the house. And that's the most common, you know, and it could be the other way around, of course you can get, you know, but it's more typically the woman with the elderly man.
You're absolutely right. It's a scenario that's not altogether uncommon. And again, I think what you have to do is support the couple through the process. And, you know, sometimes it takes time. And even though you can see that someone's exhausted, picking the other person up and forcing them into care is probably going to cause more emotional damage all round than letting them be exhausted for a little bit longer and working through things in a systematic and caring way. And there are lots of strategies that we all use, and I'm sure, you know, you all do this, but, you know, I will have conversations with the wife in that scenario and say, you know, you are heading to crash and burn. He needs you to be well. You know, if you can't think you're doing it for yourself, you're doing it for him. We know he doesn't want to go. We know that it's going to be a struggle to get him to the respite facility. But if you're going to continue to be at home longer term, you really need to give serious consideration to doing this. The respite has to be, like all aspects of care, ideally it should be in the right place at the right time. Some places and some support services have the facility to offer respite in the home. Now, where I work, that is available, but it's quite difficult because it's down to the person to find who's going to physically replace them. So the money's there. The money is there to say, you know, your husband can have respite at home while you go away for a few days. we will pay someone to come and stay with him, but you have to actually find that person. So that's, you know, that there are challenges with that. So most respite locally, where I am, takes place in residential care. And yes, it's not nice to think that you have to take people kicking and screaming to a rest home. It needs to be the right level of rest home, and they need to be experienced in managing the dislocation and distress that that might cause, because sometimes you do have to do it, whether you want to or not. And often then, you know, you need to talk to the spouse who is getting the respite. The person's not getting the respite, it's the spouse who gets the respite. You know, you need to say to them, look, we'll do this as gently, as calmly as we can. If necessary, we may use something slightly calming to help with the transition. And then, you know, after, usually people will settle, and then obviously they'll come home again. So I think, you know, it's about having the right people take the right approach and, you know, try and do things as gently and calmly and not in an absolute crisis. Yes, we're always going to get crises, but planning for things is always better. So if you broach the issue of respite before it becomes a crisis, daycare is a really useful step to respite. So we encourage people to use daycare because A, it gives the spouse a day off once a week or whatever, but it also starts to habituate the affected person to a different environment. So if the day comes when they have to go and stay there for a few days, it's actually not as big a shock, and it's not that completely unexpected unfamiliarity that people with dementia don't cope with. So daycare is a very useful stepping stone, I find. How do other people manage this kind of, how do you manage it?
With difficulty. Yeah. It's not easy. As you were talking, I was thinking about it. A male patient of mine who nursed his wife through dementia. She finally went from home to stage 4 dementia unit, which shows how bad she was. And he promptly had a stroke and died. You know, and I think so almost like the adrenaline held them together, and within 6 weeks of her going into care, he had a dense stroke and died. And I think, well, I just didn't push hard enough for her care and rest home.
And again, I think you've reminded me of another very important point. You know, people often say, when is the right time for someone to move to permanent residential care? And the answer is there isn't one, is there? And I've had the same scenario where people have struggled on and on and on and on. And eventually there's some sort of crisis usually. The affected person goes to residential care. They settle beautifully, are completely content, well cared for, and the spouse is given this new lease of life. They still see them, they still love them, but they're no longer exhausted, they're no longer stressed, they're no longer having to bar the windows and doors morning, noon and night. And they'll say, I wish I'd done it sooner. But, you know, it's not for me to tell them when is the right time. And I've equally seen the same thing where someone has maybe said, you know, I'd love to keep them at home, but I can't for whatever reason. And that person goes into residential care and they die very quickly. And then you've got a grieving spouse who says, if I'd known they were going to die that quickly, I would have struggled on a bit longer. And that's an awful thing for someone to feel. But we don't know that, do we? We're not that good at predicting when people are going to die. And it's, you know, so there's no right and wrong answer. And we just have to do our best and support people as best we can.
There's a service in Auckland, I don't know if it's anywhere else, and it's a private business where a woman's got set up basically like home help. So people come in and they do cleaning and that sort of stuff. It starts off like that, but she has a whole subset of people that are trained in dementia care. So they start off coming once a week to clean the house and do home help, and as needs increase, their role changes, and they're already a familiar part of, you know, that this person coming once a week, or then they start coming 3 times a week, and then they, you know. So I only became aware of that recently because the GNSs that I work with were talking about it for somebody. And it
sounds like a brilliant innovation, doesn't it? I'd be interested to hear more about that. Yeah, yeah. Oops. Well, that was. I'm happy to talk about this for the rest of the time. You know, we don't have to talk about drugs, but there's always lunchtime. It's always, I'm always very keen to hear how other people do things, because I know, you know, I don't always feel I've done things well, although I do my best. So I do want to just briefly touch on the medications that are available to treat dementia. Most of these drugs have essentially been researched in Alzheimer's disease and have then been more widely applied with some you know, studies that have gone on looking at impact in other forms of dementia. So there are the key ones that we use. Now, this is not about the treatment of BPSD. I'm not going to talk about atypical antipsychotics because I'm thinking that Dr. Sims is going to cover that later. But we have the cholinesterase inhibitors and memantine, which is an NMDA receptor antagonist. Don't ask me how it works, or I'll say it antagonises NMDA receptors.